Oral manifestations are among the earliest and most significant indicators of HIV infection. Recognizing these lesions is crucial for early diagnosis and management. In this video, we'll explore the main types of oral and periodontal diseases associated with HIV, their clinical features, and current management strategies. Whether you're a dental professional, a medical student, or someone interested in oral health, understanding these conditions can help improve patient outcomes and quality of life. Let's begin by examining the spectrum of oral lesions commonly seen in HIV-infected individuals. Linear gingival erythema is a distinct periodontal condition strongly associated with HIV infection. It presents as a marginal, linear band of erythema across the attached gingiva, often involving all teeth. Unlike typical gingivitis, the redness is not proportional to the amount of dental plaque present. Patients may notice spontaneous bleeding or bleeding upon probing, but there is no ulceration or loss of attachment. Importantly, this condition does not respond to conventional plaque control measures, making it a diagnostic clue for underlying immunosuppression. Necrotizing ulcerative gingivitis, or NUG, is another periodontal disease seen in HIV-infected patients. It is characterized by sudden onset, pain, bleeding during toothbrushing, and a distinctive foul odor or halitosis. The gingiva appears fiery red and swollen, with yellowish-gray necrosis at the tips of the interdental papillae and gingival margins. NUG primarily affects the anterior gingiva and is usually limited to the soft tissues. This condition is painful and can progress rapidly if not treated promptly. Necrotizing ulcerative periodontitis, or NUP, is a severe form of periodontal disease associated with HIV. It features intense pain, localized soft tissue necrosis, ulceration, and characteristic interproximal cratering. Unlike typical periodontitis, NUP is not associated with deep pocket formation, but instead shows rapid loss of crestal bone and soft tissue destruction. Tooth mobility is common, and the condition is often seen in patients with severe immune suppression, particularly when CD4 cell counts fall below 200 cells, millimeters cubed. Necrotizing stomatitis is the most severe form of periodontal infection seen in HIV, characterized by extensive soft tissue and bony necrosis with sequestration. It closely resembles conditions like noma and cancrum oris. This devastating disease can lead to significant tissue destruction and is a hallmark of advanced immunosuppression. Prompt recognition and aggressive management are essential to prevent further complications and improve patient outcomes. A key feature distinguishing HIV-associated periodontal diseases from conventional forms is their lack of response to plaque removal and good oral hygiene. These conditions may occur in isolation or together in the same patient. Recognizing this lack of response is critical for clinicians, as it signals the need for further investigation into the patient's immune status and possible underlying HIV infection. The Centers for Disease Control, CDC, classifies AIDS patients into three main categories based on clinical and laboratory findings. Category A includes those with acute symptoms or persistent generalized lymphadenopathy. Category B covers symptomatic conditions like candidiasis or herpes zoster. Category C includes patients with life-threatening conditions and CD4 plus T4 lymphocyte counts below 200 cells, mm². Laboratory categories further stratify patients by CD4 counts. Category 1 is greater than or equal to 500. Category 2, 200, 499. And Category 3 is less than 200 cells, millimeters cubed. Certain oral lesions are strongly associated with HIV infection. These include various forms of candidiasis, erythematous, pseudomembranous, oral hairy leukoplakia, Kaposi's sarcoma, and non-Hodgkin's lymphoma. Periodontal diseases, such as linear gingival erythema, necrotizing ulcerative gingivitis, and necrotizing ulcerative periodontitis are also prominent. Recognizing these lesions can aid in early diagnosis and prompt management of HIV. Some oral lesions are less commonly associated with HIV infection but still important to recognize. These include bacterial infections like Mycobacterium, avium, and tuberculosis, melanotic hyperpigmentation, necrotizing stomatitis, salivary gland disease, and thrombocytopenic purpura. Viral infections and non-specific ulcerations may also occur. These conditions can complicate the clinical picture and require careful evaluation. A variety of other lesions may be seen in HIV-infected patients. These include bacterial infections such as Actinomyces israelii and Klebsiella pneumoniae, drug reactions, epithelioid angiomatosis, and fungal infections like cryptococcosis and mucormycosis, nervous system disturbances, recurrent aphthous-stomatitis, and viral infections such as cytomegalovirus and molluscum contagiosum are also observed. These manifestations highlight the broad impact of HIV on oral and systemic health. The most common oral and periodontal manifestations of HIV include oral hairy leukoplakia, candidiasis, Kaposi's sarcoma, and bacillary angiomatosis. Oral hairy leukoplakia typically appears on the lateral borders of the tongue as keratotic, asymptomatic areas with vertical striations. Candidiasis may present in pseudomembranous, erythematous, or hyperplastic forms, and angular cheilitis is also common. Kaposi's sarcoma manifests as multifocal, vascular lesions that are brown, blue, or purple. Bacillary angiomatosis is an infectious, vascular, proliferative disease seen in HIV patients. It presents as red, purple, or blue edematous soft tissue lesions that can cause destruction of the periodontal ligament and bone. Oral hyperpigmentation is another common finding, often presenting as dark patches on the oral mucosa. Both conditions are important markers of HIV progression and require appropriate management. Diagnosing HIV infection relies primarily on serological testing. The enzyme-linked immunosorbent assay, ELISA, is the most common screening test due to its high sensitivity. Confirmatory tests include the Western blot assay and polymerase chain reaction, PCR. Direct detection methods, such as P24 antigen testing, HIV-1 RNA, and provisional DNA detection, are also used. Accurate diagnosis is essential for timely intervention and management. The primary goals in managing HIV are to control viral load, prevent disease progression, and reduce the emergence of resistant variants. Achieving immune reconstitution, both quantitatively and qualitatively, is crucial. Preventing opportunistic infections and malignancies is also a key objective. These goals guide the selection and monitoring of antiretroviral therapy and supportive treatments. Highly active antiretroviral therapy, HAART, is the cornerstone of HIV treatment. It typically consists of 3 or more drugs, including nucleoside reverse transcriptase inhibitors, NRTIs, like AZT and lamivudine, non-nucleoside reverse transcriptase inhibitors, NNRTIs, such as nevirapine, and protease inhibitors like ritonavir. HAART regimens often include at least one protease inhibitor, or NNRTI, earning the nickname drug cocktail or triple therapy. Management of linear gingival erythema and necrotizing ulcerative gingivitis begins with a thorough medical history and appropriate consultation. Scaling of affected areas and oral hygiene instructions are essential. Intrasulcular irrigation with 10% povidone iodine and 0.12% chlorhexidine mouth rinse twice daily are recommended. Antifungal agents like nystatin or clotrimazole may be used, though systemic agents such as ketoconazole or fluconazole are preferred for long-term therapy. Regular follow-up is crucial to monitor progress. After initial therapy for HIV-associated periodontal diseases, follow-up is essential. Patients should be reviewed at 1 day and 1 week post-therapy, then recalled every 4 weeks until the periodontal condition stabilizes. Once stable, recall intervals can be extended to every 3-6 months. This ongoing care ensures early detection of recurrence or complications and supports long-term oral health. Managing necrotizing ulcerative periodontitis involves a comprehensive approach. Begin with a detailed medical history and scale affected areas under local anesthesia. Remove necrotic bone and soft tissue and perform 10% povidone iodine irrigation. Oral hygiene instructions and 0.12% chlorhexidine malchium rinse are essential. Systemic analgesics and antibiotics like metronidazole may be considered, along with antifungal agents. Follow-up should be scheduled at 128 days and 6 months. Treatment of necrotizing stomatitis follows similar steps as other necrotizing periodontal diseases. In addition to medical history, scaling, and irrigation, it is important to protect the lesion with a mouth guard if possible. This helps prevent further trauma and supports healing. Early and aggressive intervention is key to preventing extensive tissue loss and improving prognosis. Oral lesions in HIV can be grouped into 3 categories. Those strongly associated with HIV, like candidiasis, hairy leukoplakia, Kaposi's sarcoma, and periodontal diseases. Those less commonly associated, such as salivary gland disease and necrotizing stomatitis, and those seen in HIV infection, including recurrent aphthous stomatitis and various bacterial or fungal infections. This classification aids in diagnosis and management. Recognizing and managing oral lesions in HIV is vital for early diagnosis, effective treatment, and improved patient quality of life. Dental professionals play a crucial role in identifying these conditions and coordinating care with medical teams. Regular monitoring, patient education, and adherence to treatment protocols are essential for optimal outcomes. Stay informed and proactive to ensure the best care for those affected by HIV.